So what I thought we would do is start by just reviewing the questions that we used to set up this session. And the presenters have each tried to give and have given examples of systems approaches to care. But I think some of these questions we probably want to talk through as a panel. So the first was, how do we ensure high-quality cancer diagnosis, treatment selection, monitoring, and course correction for the patient and as a learning health system? Do we want to? We've given our examples. Would we like to have some sort of summative discussion or crosstalk between the panelists on that question, or do you feel that we've landed that one? Mary, you look like you're primed.
I can just start by saying that I think the high quality diagnosis, treatment, monitoring, and course correction really requires that team approach that we've been talking about all day. It can't be done in a silo. I don't think any individual can make all of those decisions. And so I think that that's, changing the system so that there is that integration of knowledge across the disciplines is essential. And that's true for both the patient as for the learning system, because if you can do that, then the knowledge from that must be recorded and fed back into the learning system.
Yes, and I would advocate for just two other things that should be included. I touched on a patient-reported outcomes. I mean, we need to find out what's the patient's goals and see how we match up against that. And the other piece is capturing the clinical data, like the work in HemePath. I mean, it's so scientific and so, receptor-based. It's this really hard data, but really what you want to know is how does that patient look to you? How do they feel? What is the subjective stuff that you're extracting as a clinician? And to me, we need to figure out a way to extract that systematically on every patient, every time in the workflow in order to feed the learning healthcare system and be treating the patient and not a picture.
Yes,
and I would just add quite a few other aspects of the patient too. I completely agree.
Been provider satisfaction.
Which we haven't talked about provider satisfaction. Patients are bombarded with a variety of opinions, the Wall Street Journal, the internet, Google, everybody comes with a stack of papers like this. Patients are confused, and it's not necessarily for lack of information. It may be too much informational overload for a lot of patients. So I think if we can develop a system that reinforces quality and gives the patient comfort, it may also provide the provider with more satisfaction and less burnout. It's just one of the things that we're trying to look at right now in our system.
So from my perch, sort of the common denominator of the things that each of you talked about involves stepping back, acting as a system to align the role, the process, and the technology with a feedback loop that allows it to self-correct. Those are sort of common pieces that I think are part of this. If we try to implement any piece of decision support or any one thing separately, we will create certain things that work, certain things that don't work, and we won't actually improve the whole system.
I think the feedback and self-correction is absolutely critical to making it dynamic and alive and patient-centric.
Let's then talk about our second question. What aspects of cancer diagnosis and care require collaboration amongst oncologists, pathologists, and radiologists? We were thinking that it would be important to identify ones that did, and were there aspects of care that could be effectively done by an individual? Comments?
Steve here. I think the answer on it is all three of those require total collaboration. I mean, I can't begin to figure out how to treat a patient unless I have a pathologist and a radiologist. I trust their opinions, and when they know they need to get a second opinion, they get those. So I used to make the comment, for me to make a decision to go ahead and treat a patient, I had to trust my pathologist actually more than I'll make the comment my wife. So I need a really trustworthy system like that. And I think when we talked about pathways, from when I talked about it, we were talking about the physician making the correct decision of what diagnostics to get, which have been helped by the Vanderbilt project. But I think that part of that has got to be the things we talked about earlier today, is how do we have the radiology and the pathology correct, so when I ordered the right test, I know I'm getting the right answer.
That always also requires the oncologist's input about the patient, which as a pathologist in a laboratory, we don't have that input. And so it really is the requirement of knowing what the oncologist sees in the patient, the history, and a lot of the, what Rusty was talking about, how that patient appears, and that being communicated to us in some sort of discrete way so that we can incorporate that into how we move forward. I feel as a pathologist, we're often, especially in the oncology world, somewhat at an advantage because we have a biopsy. We kind of know what we're looking at by the time a specimen gets to pathology or a patient gets to pathology. There's usually something there to look at. And so it's, and that really does give us an advantage in helping decide what tests need to be done at that point and taking it through the rest of the pathways. I think the pathways that were discussed are very similar to our SOPs in integrating the clinical history, lots of the presentation, patient physical exam even, and then putting it together with the laboratory testing.
Yeah, I think one of the critical things right now has been the explosion of scientific knowledge, that the clinician is overwhelmed with the amount of information that can be provided. Trying to sort through that and provide a succinct, meaningful interpretation of the data is truly a problem.
We use the word collaboration as if we all know what it means. Could each of you identify an attribute that is central to defining collaboration from your perch?
Frequently talking to one another.
Trust.
Partnership.
Number 2 for partnership.
Having a relationship that when you feel something isn't right, you can easily talk about it and feel confident with each other that you're doing it for the right reason.
Thank you. How does a health system form the right interdisciplinary team for patients with cancers?
I'll start that by saying, this system approach that all of us are talking about in some way or the other that requires integration of clinical decision support in some format, whether it's to the physician or along pathways where the physician actually is freed up for more time with the patient, which I think is a huge advantage. That kind of systems approach has to be supported from leadership through the healthcare system itself. And that's one of the reasons that I think it's worked at Vanderbilt. But that would be, it has to be from the top down in a lot of ways in bringing those people together and incentivizing the people to work together.
So the way we build product at Grand Rounds is we bring in a bunch of patients and say, here, try this. Do you like it? Do you not like it? What do you like different? So I would advocate that we need to start with the patient, and at every step with the patient, like, what's it like to call in to get an appointment? What's it like to park here? What's it like to be in our waiting room? What's it like to be in our clinic room? What's it like to be in radiology? What's it like to wait for your diagnosis to come in? What's it like to try and schedule your surgery? Like, that's the process we have to fix. That's the reason why people are so fed up with us, is because we have not thought that way. And so I think we just have to take an incredibly purposeful, patient-centered approach to figuring out what's wrong, and then we can figure out what we need to apply against it.
How do we incentivize collaboration amongst the oncologists, pathologists, and radiologists?
Well, that was the point I wanted to make about interdisciplinary teams. They are labor intensive. And the way that most of the system is designed, you're not paid for that process. And that represents a real challenge, particularly as we develop more subspecialization, that the bandwidth for an individual subspecialist can be awesome and overwhelming. So I think we have to figure out a change, and we've heard about some of those changes in the reimbursement system to make it work.
Yeah, I'll comment on that too. I think the driving force will be reimbursement here. And I think when we're all responsible for the total cost of care, you'll find who you want a partnership very quickly, who is the efficient person that gets the job done quickly with high quality, and then it reduces the cost. I think that'll drive us all to do it.
Okay, one last question and then we'll open it up. How do we scale interdisciplinary cancer care to the community? And in this case, let's take for the perspective of independent community practitioners, either oncologists or primary care clinicians.
So since I was an independent oncologist, I can comment on that. We had our office near our hospital system, but the hospital system was in Delaware, was able actually to put together interdisciplinary tumor conferences, number one, but also then we had clinics. We had a full array of the different types of physicians in the clinics. Even though we're all independent, we met at the hospital, saw patients together, and then took care of them in our office thereafter. But the important thing of that is not only did I think it improved diagnostics and therapeutic decisions, actually there was an increasing bond then between the multidisciplinary team by doing that. So I think in larger communities, again, there's barriers to get through on that one financially, but you can do that. I think the big issue is with the Project Echo, how do we do this with our colleagues that are sitting out in the remote rural areas? And again, they're going to have a different way to do that.
I think the real challenge will be how long can those systems exist as we change reimbursement models, as we change industrialization of care delivery. I think a real challenge will be how long can people exist in our current practice environment of a small 2 or 3 man practice, you know.
And I've struggled with this question as well. Like, we thought about taking this expert panel that we have, you know, for patients and having it available to practitioners as a curbside consult, and have it be available, you know, whichever tech modality you want. The challenge was figuring out the business model to figure out who would pay for that, and could never figure that out, so we never deployed it.
Okay, questions from the floor.
Thank you very much. This has been a very stimulating discussion. And maybe to kind of connect this with what we talked about this morning, this tension between specialization and a more generalist model. One theme that I see coming across here is that what it seems like all of these approaches pretty much leave the local team intact and then support the local team rather than supplant the local team. And some of the conversation this morning felt like, you know, we've got specialists, and the objective really is how do we get those specialists directly in kind of in instead of the kind of the local team. And I'm very concerned about that because I think that, you know, there's a lot of value, as you talked about, trust and relationships and partnership, that what a local team brings to the table. They may not have all of that high level expertise, but they have those relationships, whether it's relationships with the patients or it's a radiologist has relationships with the local referring clinicians. And so I'd love for you to comment on that concept of supporting those teams versus, you know, maybe it's easier if we just take on that responsibility ourselves.
that's sort of what Project ECHO is all about. And you're not going to build capacity if you're not nurturing capacity and providing the skills and the relationships and the knowledge to the local physicians. But we'll never have enough subspecialists to cover the country evenly. And so there's got to be a way to provide, sort of like I said, not to provide the same subspecialist level of expertise in the communities, because you just can't do that, but maybe find some middle ground so that the local physicians will be able to provide more than they can now. And there's a lot of challenges. I didn't talk about the challenges. I mean, to do this, you need to have champions in the academic center, and then you need to find the right people out in the community, because nobody's got the time, and this is just one more thing to do. And so you have to find somebody who's really passionately interested in maybe moving up a notch and being able to provide services that they were not previously able to find. Once you get that community champion, they tend to be able to bring others in with them. And so it really is a bit of capacity building in that way.
I think you've alluded to a complex dance that's challenging. Oncology is protracted, except for the surgical experience, is protracted treatment. And it's sure nice to have it close to home, where your support system exists. That assumes that close to home provides the same quality as the central organization. But, you know, unfortunately, our reimbursement system has not been designed to facilitate that kind of environment. And I think hopefully as our reimbursement system changes, this kind of environment can evolve. But it's going to take give and take on both sides of the fence, I think.
And part of this is knowledge that needs to be disseminated to the patient. So I have another slide. If you look at all the patients that got Whipple procedures, I don't remember who brought the, that's when the pancreas gets ripped out, that over half of the patients that got Whipples, I don't know if it was in California or in the United States, were done by people that do like less than 5 a year. But then if you actually map where they live, they were within, like 90% of them were within 200 miles of a high volume practitioner, someone that does more than 5. And so like, if you were the patient, I mean, part of this can also be enabling the patient to also just seek out maybe a more specialized care when appropriate. The problem is the data is not really readily available unless you spend a lot of money to try and accumulate that data.
Yes, sir. Oops, I'm sorry. Over here.
Türkan Gardenier from Pragmatica. I'm very impressed with Ellen Baker's ECHO program and Rusty Hoffman's one-page 8th grade level summary for patients. And I'd like to make a couple of comments relative to perhaps being helpful in terms of data collection in the future. National Academies has had a Patients Like Me program for a while, where patients interact with each other. And there was also another program where we watched how much genomic data collection results should be referred back to the patient. Number one, the ECHO program is wonderful because it is on video. And also, since you have the patients available, you can ask about genetic data, family history data, which we fill out every time we go to the doctor to get mammography or imaging. I don't know how much of that information, family history, is integrated into information for patients or for physicians at this point. In another meeting, the importance of family history data and environmental factors were also emphasized. So if you're talking to the patient where they live, what kind of food they eat, if there are pesticides involved in the food they eat, would be informative in terms of cancer probabilities. In terms of 8th grade level, I'm not sure if you're incorporating genomic data into the patient's one-page summary, whether that is appropriate. Because as a statistician, I'm aware of the low correlations between the cancer genomic analyses and the level of research information and analytic capability that has progressed so far. So in terms of, for example, information of results obtained from reports that are conclusively reliable, I would very much encourage that one-page summary so patients are aware of where they stand, and I would discourage probabilities for contracting cancer from results of genomic analyses. Thank you.
Thank you. Yes, sir.
So just a quick question for each of the panelists, especially the diagnostic management teams. I think I've followed Vanderbilt's exercise diagnostic management teams and been impressed and inspired. And I wonder, so this question is primarily for you, but also for all of the panelists, is you've given great examples of what your individual institutions or individual companies have done to improve system-wide care within your systems. What have you done, and creatively, what more could you do to empower others to use similar to do similar things that you have done?
I guess what comes to mind first is that, much of what we have done has been published because we are an academic center. So all of our data is published except our analysis of the NGS, which is still under development, and we're working on that. And so I would encourage anyone to read those papers and to do that. We would we've actually hosted people to come and see what we do at Vanderbilt and how the system actually works in person. As far as other academic centers or anyone across the country, we're encouraging other people in the Southeast region within the VAN network to use our system. So we've gone out and we do grand rounds all over the state. The number of times I've driven to Memphis and Jackson and northern Mississippi. So those are ways that we're trying to impact our local region and sort of the systems of patients that we feel that we're really responsible for right now. So that would be...
That's wonderful.
How we're doing it.
How about others?
If I can comment, I think the two things that'll drive the utilization of these, and I think they were both covered in the talk from Vanderbilt, was number one, does the physician and the providers get their job done easier with less hassles and makes their life better? That's number one, which I think you showed the minute you adopted those. The time you had to spend ordering tests went down. And again, I think the second part of it will be the financial analysis. When you put these things in place, if they cost you some money electronically to get them up and running, will your practice, will your healthcare system come out ahead on the financial side? So I think as we do these, I think there needs to be a financial analysis with them.
So mine was back to patient-reported outcomes. My area of expertise is really if people have occluded IVCs and iliac veins, they could be occluded for 25 years. I can stent people from their right atrium to their femoral heads, and they can block again, and they don't have leg swelling, they don't have venous claudication, they don't have ulcers and stuff. The problem is, I'm like, hey, how are you doing? Like in follow-up, when I see them follow-up, like, oh, I'm much better. I'm like, okay, much better. Like, or I'm a little bit better. Okay, what's going on? And so what I did was just went to the literature and got validated questionnaires related to quality of life for DVT, as well as lymphedema. I treat patients that have swollen legs from lymphedema after surgery or radiation, and implemented that using the software program that was developed at Stanford by a pain physician named Sean Mackey. It's called Choir, and it's actually freeware. And so it allows us to input these instruments, and then the patient gets an email, an automatic email, and they just click on the link and it opens it up and they can answer it, as opposed to using Epic and MyHealth where they have to log into the portal and do that. That's too high a friction. And we have like 5x the utilization with our Choir tool. But what that allows me to do when I see a patient initial in consult, I can get an idea of how severe their disease is on a validated scale. After I treat them, and it's got a graph, the report graphs out how they do over time, and I can show it to them, and I can also look at it for myself. And then in addition, we actually made software that is specific to venous disease, where my nurse practitioner clicks all the different things I want to understand related to physician assessment, DVT risks, and risk factors, and you hit generate note, and it makes a note for you, and you copy it and paste it in the Epic, and then it's done, but your data acquisition occurred right there.
The question is if you're doing anything to help others, to others know the quickest and easiest way to be able to get that information to the patients outside of your system.
Well, I'm a big believer in if you build it, they will come. So I want to prove feasibility in my own clinic. So it's actually a manuscript that is out now that then hopefully that they would people would adopt. But the good news is the success there has wanted all my other partners to adopt it within the interventional radiology section.
Rusty, quick question. Is that data then capturable in your Epic system, or is it?
Yeah, so the copy and paste goes into Epic, but all the interesting data I've already collected outside of Epic and stored it in a database. In a different database,
okay.
Yeah.
Again, as we at ASCO, as we try to continue to collect electronic data, I can tell you having data in all these different sources is making it very difficult to kind of look and see what's happening across the board with everybody.
I wanted to also comment about that. Our data is also outside of Epic, but it is can be accessed by almost anyone. Our first software application was not scalable and not really accessible to other EHRs. And so in the last year and a half, one of our hematopathologists that has informatics expertise has developed, Aaron Shaver has developed a new application that we're just begun to pilot that will automatically do the SOPs for us. There's an amazing amount of human error even in following SOPs. And so the new application will do that and then pull all of the information. But it does reside outside of Epic. And so we're pretty comfortable with it right now, but it still isn't complete. So that would be one of the ways that we would be able to partner with other people.
That would be wonderful. Thank you.
Yes, ma'am.
Thank you. Excellent conversation. Thank you all for the programs that you're sharing. It's really obvious that there's a tremendous amount of work being done to move this forward. My question to the panel may be inherent already in the programs you described, but I think it bears just highlighting just a little bit stronger for me. I heard very clearly the importance of the collaborative team of the oncologist, the radiologist, and the pathologist. Although hearkening back to the data that I referenced earlier quite rapidly, when I look at the bigger picture of diagnostic failure in the oncology story, more than a quarter of those claims live within our general medicine providers, family medicine and internal medicine. Our patients aren't even reaching the triad of the oncologist, the radiologist, and the pathologist. And as we talk about building the diagnostic team, I'm looking for how your teams are reaching and embracing your primary care providers who need to be able to call upon their radiology and pathology peers to think about the right tests, to understand better the tests that are being fed back to them, so that there's some collaboration there in order to be sure that our patients are being captured earlier in that vulnerable place and then brought into the safety of the broader net as well.
Well, at Intermountain, we have, like we have an oncology clinical program, we also have a primary care clinical program. And in the primary care arena, they have scorecards and spreadsheets and prompts. We've heard about prompts in the EHR that tell them what tests to be done when for cancer screening. But this is the sort of part of the population that goes to see the doctor. I treat cervical cancer, and 40% of the patients I see have never had a pap smear. And they've never been to a primary care. So that's a big challenge.
Sure.
Other response to that?
So I'll comment on that. One of the things we've conceptually done at ASCO is work on the other end of the spectrum is after treatment, how do you reinvigorate your primary care community with the survivorship care of the patient? And anybody that's taken somebody through the horrors of cancer treatment, there's a bond there that's hard to break, and to send them back to the primary care physician is sometimes very, very difficult. So I think that's one of the areas in ASCO we're looking at is how do we bring the primary care physician back into the appropriate testing, not over testing, and make that transition over time that's both comfortable to the patient and to the physicians.
Thank you.
Yes, sir.
Hi, John Gardner, research ethicist. Before I was doing that, I had the privilege to do some in-depth study of systems analysis and general systems theory. And the one thing that has stayed with me since then is nobody doing systems work adequately investigates the problem. Problems are always more complex and more difficult because people don't want to spend time on that. They get an idea what the problem is and they want to go to a solution. And you people have done that, and I am delighted to see the excellent progress you're making on viable systems that actually address the problem as you have defined it. Let me suggest 3 aspects of the problem that you could possibly expand your work into, and just ask you, do any of those attract you as an additional consideration for the work that you're already doing? My first concern, which I mentioned earlier, is that our whole medical model is to wait till the person gets sick, then do our testing and diagnosis and treat the problem. What we would be much better off doing, if we could do it cost effectively, is to help ward off the problems before they occur. We hear from time to time about preventative medicine, and people here today have mentioned it. So my question with regard to that is, to what extent could the work you're already doing be expanded slightly to help community practitioners especially do a better job of preventative medicine to help reduce the risk of the patients contracting cancers in the first place? All right. Another issue concerns the providers. What I've heard today is you're not only concerned about the patients, but also physician or practitioner burnout. That's very good. I was very shocked recently. I get a lot of emails from the National Academy of Medicine, which I'm delighted for, and my wife and I attend a lot of these sessions. But one that I had never heard of, not in the popular press nor from the National Academy until just recently, is a study now addressing the crisis of nurse suicide. I have no idea what that is or what's going on or what's happening, but I didn't hear any indication that anybody here in the panel or in the whole workshop was aware of anything that could be called a crisis of nurse suicide. So I don't know. but is that something that you would be interested in looking into as well? My final point is patient. I hear patient as a term that defines the person who's seeing a doctor as a fairly simple thing. In bioethics, patient is a very complex thing. First of all, it's never one person who's seeing a doctor who's affected by that person's health issue. The family is very much affected, and sometimes the family is a vital part of the communication. And sometimes one member of a couple, or if there's a child, they can't be the only one communicating with your system, no matter how good your system is. And the nature of the patient with the family is something a community practitioner may be well aware of, but I think should the practitioner that you're advising also be advised to consider the family situation when looking at the patient, and also patients are not uniform. Some people approaching the end of life in a cancer situation would spend all the money they have and all the money in the family budget to prolong their life one day. This has been documented. That's a minority opinion, of course. Others of us, like myself, have no interest in living beyond the point of a certain quality of life. So there's a wide variety of ways in which patients value and assess their own medical situation and prospects for treatment. Some people don't want treatment. Some people don't want to know their test results. Somehow or other, the ethical question exists, whether we choose to look at it or not, is what do the individual patients actually want from the medical system? So just those are some additional suggestions. I don't know how many of them you choose to deal with.
I can talk about the family piece pretty quickly and easily. So I mentioned, my son had a bone marrow transplant from me. He's alive and healthy, thank God, and surfing and has got a girlfriend and doing well in school. So like living two years with a critically ill child, put that into square perspective, and then trying to keep everyone in my family up to speed and, the like. So with this document that we write, for the expert opinion, that gets posted on the portal for the patient. The patient can share that with whomever in the universe, as well as their treating physician. And part of that, there's also a message center. So just like on your cell phone, where you can text back and forth and it's kept chronologically, all communications with grand rounds or between the provider or between patient and family members is all there. So everyone can be kept up to date on what's going on medically, which is different than like a caring bridge, which is more the social support that's going on. So I'll take that one. I'll let other panel members take the rest.
Yeah, I can comment on that. I mean, I think what you just described, all the aspects of taking care of a new diagnostic problem for any disease, comes down to, do you have effective clinicians or not? And an effective clinician takes all that into consideration, is able to explain things, maybe not at an 8th grade level, but in common language that people can understand. And I have to tell you, in my practice, it was rare I had somebody come to my office to see me that didn't bring family with them. So again, they're a key part of the whole thing.
Thank you.
Okay, I'm Patty Spears, patient advocate, and I really like that the patient is really coming into the conversation really well. And I'd like to just kind of, when patients come in with a lot of information, I actually speak to early career scientists about it's their responsibility actually to get the good information out there and the correct information out there, and that's a responsibility of science. It's a responsibility of physicians to actually counteract all those USA Today stories and all that. I'm sure you're all talking about asparagus now. But I think that that's kind of the responsibility, and they want to know that information, and so to kind of give it to them. But really what I'm interested in is the patient side of visit. So we talked a lot about the system and how you can save money in the system and time in the system. When you look at those systems approaches, do you look at the time saving on the patient side, like less visits, less copays, things like that, burdens that are on the patients that you can save as well in the whole systems approach? And also wanted to put a shout out for patient-reported outcomes. And if you are getting them electronically captured, sharing them would be really good so that we could really come up with some good methods about looking at patient-reported outcomes, because my thing is it's really nice to gather them and to get them, but how are we going to get that information back to patients? I think we don't have a good way of doing that.
I can agree with you. I don't think we have a great way. Most of my patient stories are really secondhand from the oncologists that tell me how they use our system to interact with the patient. We have a flow chart that's part of our application, and Madan Jageshis has told me that he'll open that up and show the patient sort of through the course of their disease, when they got their therapy, how their blood changed, what the changes in their mutations were. And we've considered the possibility of trying to do a comprehensive report for the patient, which would be very, very different. And we haven't done that, but it's been one of the things that we've discussed in the past. So thank you for your question.
Yeah, so one of the major focuses of our system is to keep people home and keep them around their support system, going to school, helping with their kids, whatever they need to be. So our real focus has been to push high-quality care out rather than bring the patient in, for all the reasons you mentioned. A little anecdote about patient-reported outcomes. We have really struggled with this. I mean, in some diseases where they're absolutely critical to decision-making, we get a third replies, a quarter replies. It's not as easy as it sounds, or we're doing something very wrong.
How are you trying to collect them?
How are you collecting?
We do it. We send out an email. Yeah.
And they just click on it and open it up?
They don't even, well, some open it up, some click on it, some delete it,
I think it's a matter of...
But it's a challenge, yeah.
It is, but I think as a patient, and I did a lot of patient-reported outcomes, but I think you ask a lot of questions that are not dealing with what they're dealing with. So I think there's a push now to ask really relevant questions. And so I think if you ask less numbers but relevant questions...
That's what we tried to do, right?
Yeah, and then also as a patient, and you go in and they say, you've got to get that scan, you've got to get that MRI, but they don't say you've got to fill out that form and what's going to happen with that form. It's kind of like, oh, by the way, can you fill this out when you've got time or whatever. It's not given the same importance. So I think if it is, it might be filled out. So Rusty, I think.
And I think patients need to have confidence that somebody's actually going to look at the form and maybe even act on it, which is the reason that I almost never fill out any of those forms. I'm pretty sure it goes nowhere.
There you go.
Confessions.
It looks like we've addressed the major questions. So from my perch, I'd like to say I hope you take the morning, which shows the gap in performance of the system as a whole. And you take this panel, which are examples of the fact that if we look at a problem and when we can't figure out how to make a win for the clinicians and the patient and the different diagnosticians, in essence, taking the system up one level, which in essence increases who you've got to collaborate with, but also allows you to solve problems that you can't solve down a level. Each of these examples, Rusty's going directly to the employer. I mean, if you've got the data, they'll pay for it. If the echo is going directly to the resources that are present in the community, but not informed, go on through the system. Instead of trying to do the payment model first, we got to fix the delivery system so the payment model can fix. And we got other examples of that. So I hope this session creates a sense of urgency that we actually can deal with this complexity and deal with it in single-digit years, while it will still matter to all of us. So thank you.
Now, this is a pleasant announcement. Just to remind, first of all, thank you. Thank you, all of you, for being here. There is a reception follow right now, and it's upstairs on the 3rd floor. So if you can take the elevator, and we'll see you for a glass of wine, glass of water, or anything else. Thank you.